Good morning, good afternoon, good evening, everyone, depending on which part of the world you are connecting to this webinar on policy frameworks for sustainable HIV and healthcare financing. I will be your host today, and it gives me great pleasure to welcome you to this second webinar of this series. I will tell you a little bit more about our webinar today. And for now, as you come in, I just wanted to give you some housekeeping and session guidelines. You have on your screen, both in English and French, the housekeeping and guidelines for the session, key points in terms of audio. All participants are muted to ensure a smooth session. Please share your reflections via the chat. We will address questions during the Q&A segment towards the end of the webinar. This session is being recorded and it will be shared afterwards. And please, if you experience any technical issues, kindly notify us in the chats. We will do our utmost best to support and do troubleshooting. So today, our session will be structured around an agenda that I will give to you in a minute, but I just wanted to move back with the slides so that you could also understand how to access closed caption in Zoom and be able to follow the webinar in the language of your preference. Captions are available throughout during the webinar, and you have in this slide the steps that you need to follow to have captions of your preferred language. You need to select which language you would like to receive your captions in, either French or English. For that, you need to look at the bottom of your Zoom screen, find the Show Captions CC button, click Show Captions, choose your preferred language, and if you don't see the CC button, click the Options button with 3 dots at the bottom of your screen, select Captions, choose the language of your preference, and your captions will then appear on the screen during the webinar. I hope this is clear to all of you, and I wish you the best experience in terms of accessing the captions of your preference for you to be able to follow the webinar. Today, we will have a panel of speakers who are experts in their own rights, experts in the matter we are going to discuss. Like I said at the beginning, I'm going to be your host. I'm going to moderate this webinar, which will last for about 90 minutes. My name is Magda Robalo, and I'm the co-chair of the HIV Control Working Group, which is African-led and is based in within CIDES in Lusaka, Zambia. I also have the privilege of being the co-chair of the Universal Health Coverage 2030 Steering Committee, and I am the president of the Institute for Global Health and Development. We will have as speakers 5 renowned experts from the continent: the Honorable Commissioner, Dr. Lita Musimi Ogana, Mr. Nelson Otoma, Dr. Benjamin Judalbai, Dr. Alex Coutinho, and Mr. Pedros Cosa. I will give you some more details about them when they will take the floor to give their perspectives and insights during the webinar. So our session today for this second webinar on policy frameworks for sustainable HIV and healthcare financing is structured because first it comes as part of a series. We are going to have a third webinar in a couple of weeks' time. And a couple of weeks ago, we had our first webinar. In our first webinar, we focused on domestic financing mechanisms and the reality that many countries are now navigating an increasingly uncertain financing environment. One of the clearest conclusions from that discussion was that sustainable HIV financing does not happen by accident. It requires deliberate political, financial, and institutional choices. So today we are going to take that conversation from the first webinar a little bit further. This second webinar asks an important question. What makes financing mechanisms survive political transition, fiscal pressure, and changing donor landscapes? The answer is not financing alone, as you all know. It is also about law. It is also about policy. It is also about governance, accountability, and the protection of the populations most affected by HIV. And you will also understand that HIV is in a context of a broader burden of disease that will benefit from whatever financial architecture, governance architecture, and accountability mechanisms that are put in place. Across the African continent, countries are being asked to sustain the HIV responses and broader health responses while managing fiscal constraints, transition negotiations, and growing pressure on national health systems. Yet, many financing commitments remain insufficiently protected within legislation, national planning frameworks, and broader governance systems. At the same time, legal and social environments continue to shape who can access services, who remains excluded, and whose needs are prioritized within national responses. As the co-chair of the UHC 2030 Steering Committee, I'm well placed to tell you that right now, 4.6 billion people around the world don't have access to basic health care services. So today's discussion will move across four interconnected dimensions. The first dimension is enabling legislation for sustainable financing. The second one is alignment between national strategic plans and broader health and development frameworks. The third dimension of today's discussion will be on continental policy coherence and transition governance. And the fourth but not least, is the legal environments that affect populations most impacted by HIV. I want to mention that our goal is not only to reflect on challenges, but most importantly, to identify practical, solution-oriented, legislative, policy, and governance actions that countries can advance within their own context. We are grateful to our speakers and participants for joining this conversation, and we look forward to a rich and practical discussion, to an interactive conversation with you through your questions in the chats and during the Q&A session that we will have later on during the webinar. So right now, and before I invite our first speaker to join us on stage, I would like to invite you to an exercise with Mentimeter and using the code on screen or scanning the QR code to answer one important question. So this is your code. On your right side of the screen, you have the QR code, which you can scan, or you enter the numbers on the left side, the code on the left side of your screen. And what we want you to do is to answer the question, what do you see as the biggest barrier to sustainable HIV financing in your context? This short interactive Mentimeter poll will help us understand better the realities and the priorities emerging across different country contexts participating in this webinar. So please, we want to hear from you. Later on during the webinar, we'll also have another Mentimeter exercise. Thank you. I see 8 responses out of 20. Political will, domestic financing, donor fragmentation, dependence, policies, health economic data. You're doing well. Yes. Lack of ownership is also coming up, corruption, foreign aid dependence, HR, ownership, poor resource allocation, but we see a big focus on donor fragmentation, political will, as being a big barrier to sustainable HIV financing in your context. Poor understanding of HIV, reorganization of budgets, debt burden, denialism, Okay, thank you very much for participating in this interactive poll. Thank you for your responses. We'll continue to look at them and analyze your reflections. Let me now move to the next segment of our conversation today, and it is my great pleasure to invite Dr. Lita Musimi Ogana to take the floor. Dr. Lita will begin our discussions, and we are turning to the legal foundations that shape financing sustainability and accountability. I'm indeed pleased to invite Dr. Lita Musimi Ogana, who is a member of the African Commission on Human and People's Rights and chairperson of the Committee on the Protection of the Rights of People living with HIV and those at risk, vulnerable to, and affected by HIV/AIDS in Africa. Dr. Lita will help us examine where enabling legislation exists across the continent, where important gaps remain, and what durable legislative protections for sustainable HIV financing can look like in practice. Dr. Lita, the floor is yours. Thank you.
Thank you very much, moderator. I would love to take the floor now, but please indulge with me because I have to enter into another assignment. I'll join you after 30 minutes to make my statement. I thank you.
Thank you, very much, Honorable Commissioner Dr. Lita Musimi Ogana. We will then come back to you. With that change in our program, we are moving to the next segments where we will have the pleasure to listen to Mr. Petros Koza, who's bringing country perspective and national strategic plan alignments for countries. And we want to ground this conversation in country implementation realities. Mr. Petros Koza is the acting chief director at the National Department of Health in South Africa. He serves as the director for the HIV/AIDS conditional grant and NGO funding within the National Department of Health, where his portfolio includes oversight and management of the comprehensive HIV and AIDS conditional grants and the finances of South Africa's HIV and AIDS program. Mr. Koza will help us reflect on how national HIV strategic plans align with broader health sector priorities, financing realities, and program implementation. Mr. Koza, thank you for joining us today. I'm sorry I can't do the click. And you have 10 minutes to enlighten us on implementation realities from your experience at country level. Thank you. The floor is yours.
Thank you, Chair. Thank you for welcoming me and the invite as well to participate in this very important topic. I thought it was going to be quite an easier task for me to have to come through after Dr. Lita had spoken in terms of laying the foundation. But I think that being as it may, the situation still allows that we are able to really share and ground and frame some of the discussions that we'd want to share with the colleagues today. So I'm based in South Africa. I'm in the HIV and AIDS program. We deal mainly, as you know, with one of the biggest kind of program that we're managing or running in South Africa. Of course, it's said to be one of the biggest HIV treatment programs in the world, given the challenges that we're sitting with in terms of caseload. But then in terms of the just issues I wanted to quickly highlight that I think mainly it will be on four main topics. Firstly, I think the issue around alignment in terms of strategies. There's usually an issue around saying how then do we ensure that we have one common goal in terms of implementation, that all necessary stakeholders and role players get to play their part in ensuring that the national targets are achieved. So in this case, I think the advantage we have in South Africa is that, as you know, and it applies in many countries as well, we have the National Strategic Plan, of course, that being a national multi-sectoral plan that has multi kind of stakeholders from civil society, government, and also private sector playing a role, and of course led in the president's office. So the usually when we do not have, and I think it's also my theory that whenever we don't have one plan, sort of like one MNE, the document that looks at or whether we're achieving what we setting ourselves to achieve, but then we will never be able to really check whether we are coordinated in our response. So I think the issue around having one plan, costing it, getting to know exactly what the costs are and what it will take for you to be able to implement. The challenge that we're sitting with, I think that comes across most of the time, is that unfortunately for most South African countries, this is actually something that when it comes to cost relies on foreign assistance rather than domestic funding. Whereas I think in South Africa, the advantage we have is that the bulk of the response is actually funded by domestic resources and, of course, augmented by donor funding, mainly being PEPFAR and the Global Fund. But then I think the importance that I would say that comes through in ensuring that what needs to be achieved gets achieved is that, for instance, when we have what we put as commitments as a country, we adopt that we want to implement this, we need to really be deliberate in ensuring that we commit, we stick to that commitment, ensuring that we implement. For instance, South Africa, the universal test and treat, as soon as it became available, we adopted and implemented. Now, when we realize that there's an issue around the challenges with how the program is being implemented more than 20 years later, we then had to go into innovative kind of modalities that comes through, such as the differentiated service delivery. In this case, really implementing, focusing mainly on community-based services, pushing adherence clubs, ensuring that the stable patients are all decanted, but they also then we implement the multi-month dispensing. Those we've actually found as cheaper kind of modalities, but effective as well in terms of ensuring that the patient experience is improved. But also, thirdly, it decongest our facilities and ensure that other services are seen. One other point that I think I need to highlight here is that the program, as you know, it's HIV, yes, and TB, but it's performed or implemented in a platform, in this case then being the primary healthcare. And of course, we've got to then ensure that areas like, issues such as the maximizing efficiencies and costs play a major role. And in this case, for South Africa, for instance, as you would know, in 2025, the whole world being in fact affected with the US stop work orders, and also the subsequent then eventual US aid, withdrawal. That affected us in South Africa as well in terms of program implementation. And of course, we know that our colleagues in the continent also got affected in varying kind of levels. So we've got to then ensure that we maximize whatever small resources or little resources that we have to get the maximum output. And in this case, issues such as integration really plays a major role in ensuring that we don't really run vertical programs. We actually try and incorporate those in the mainstream kind of primary health care. For instance, when we then have a lay counselor or a lay person who then does HIV testing, that does the screening for NCDs as well, but also get to look at other, if they are in facilities, they assist also in getting the vital signs and all that for all patients that are actually in triaging rooms before they actually get to see clinicians. So those are some of the things that we think we need to really look into. The other main issue is this issue around on the health economics. Obviously, everybody seem to be get towards saying we should get more money. And we know that governments, the economies are not growing at the rate at which they're supposed to be growing. Donor funding is actually shrinking and all of that. So we've got to really maximize the real small dollars that we have available to ensure that we do that. So the issue around more money for health becomes a goal that we still would want to drive towards, to ensure that we mobilize resources so that we then have more money allocated into health. But that we should ensure that that does not become a straitjacketed kind of funding that then looks at a particular program like HIV only or TB only or NCDs only, but then becomes integrated in how we get to implement that. And that is actually a biggest challenge. Let me highlight that part. It becomes a biggest challenge when the funding is actually donor driven, because then in that case, donations or donor support comes with conditions, and it might be an issue that they are not able to cover some of this, and therefore integration gets compromised. Therefore, which then pushes the fact that we need to then ensure that we push domestic funding to come through in an integrated fashion, that we're able to implement what needs to be implemented. And then the issue around the more money for, more health for the money, then deals with the issue around the integrated programs, but being cost effective in how we implement our programs. I think, Chair, those are some of the issues that we need to get to ensure that we highlight. I mean, forging partnerships and thinking about HIV or TB program of old, whether it was DOT program, direct observation of treatment programs, or it was the or home-based care of old that we had. These were program interventions that were supporting these programs at the community level, and in most cases, these were actually not cadres there when actually not funded in the past. But we got to a point where people were patriotic, supporting what needs to come through. Now, with the little money that we have to be able to fund those programs, let's really get to maximize what comes out of those areas, that being in the community-based. And we need to really ensure that we forge partnerships with the CBOs and NGOs, philanthropists, but also private sector that gets to implement or is available in our respective countries. And in closing, I would say, I think the issue around program financing or HIV program or TB and HIV program financing will remain with us for as long as we still remain as a continent funding our programs mainly mobilizing or relying on the donor assistance. I think the challenge that sits with all of us is that we need to then get to a situation where our own governments get to allocate resources to the program, but on our side, then it's incumbent upon us to ensure that that one plan, strategic plan that we have, translates into strategies for implementation, broken down in terms of activities that are costed, where we become cost efficient, and we ensure that we maximize all resources that we have. Strong supply chain systems, human resources that capacitated, but also communities that are able to ensure that that gets to be implemented. And with that, I really would have loved to have more time to get to share some of the insights, but with that, I hope I've addressed some of the issues that I wanted to highlight. Thanks, Chair.
Thank you. Thank you very much, Mr. Pedro Scosa. We just heard from Mr. Pedro Scosa from the National Department of Health, South Africa, where he is the Director of Program Financing. Thank you for sharing those perspectives from where you sit in South Africa and highlighting the important role of integration into primary health care, but also coordination and detailed costed activities to guide implementation, make sure we pay attention to the supply systems, and don't forget partnerships, including the private sector, civil society organizations, but most importantly, the communities. So our dear participants, ladies and gentlemen, thank you for being here. Thank you for staying with us. We will now move to our next speaker, who is Dr. Benjamin Judalbai. Dr. Benjamin Judalbai is the Director of External Relations and Strategic Engagements ad interim at the Africa CDC. We are expanding this discussion from national implementation to continental governance and sovereignty. Dr. Benjamin brings a continental policy and governance perspective into this discussion, particularly around transition arrangements, policy coherence, and the relationship between national implementation and African Union commitments. It will help us examine how countries can strengthen policy coherence while safeguarding national ownership, accountability, and sustainability within evolving financing and transition arrangements. So without further ado, please help me welcome Dr. Benjamin Judalbai for his remarks and insights within 10 minutes. Thank you, Benjamin, for being with us today.
No, thank you so much, Dr. Magda. Let me thank the organizers and really acknowledge the importance of an African-led conversation on sustainable HIV and health financing. As you said, I am the Acting Director of External Relations at Africa CDC, and I oversee the work around policy, health diplomacy, partnerships, and of course, you know all that the mandate of Africa CDC is to support member states to build a resilient, integrated health system, not just vertical programs. I will focus on how our continent commitment translates into national laws and budgets, and how transition agreement can either reinforce or weaken, sovereignty and sustainability. Having said that, let me recall some of the key continental frameworks that we have that are guiding, the HIV response today. We have the AU catalytic framework. We have the AU roadmap to 2030, the Lusaka agenda that all of you know, and other Africa-wide commitments on HIV, universal health coverage, domestic resource mobilization, and health security. So these frameworks are strong on political ambition, but unevenly reflected in national legislations, public financial management, and rules. And also in terms of social protections. So let me just give you two concrete illustrations. One, a commitment to increase domestic health financing or domestic health spending is there. The commitment is there to increase, but HIV budget lines remain off budget or heavily dependent on off-treasury projects accounts. That is one. Two is the commitments on human rights and non-discrimination that most of our member states have subscribed to, but gaps in legal protection for key and vulnerable populations is still there. These are really two concrete illustrations. So now, what policy coherence means is what head of state, for instance, signed at AU level must be visible in the budget laws, in procurement rules, in social health insurance, and how services are purchased at facility level. That is extremely important. That is what we want to see. When we talk about policy coherence, it should go from the continental level, cascade down really to the facility level, and translate into, the reality for our populations. Now, in terms of transition agreement and governance and sovereignty, we are entering into a new area where traditional external HIV funding is plateauing or declining, and the transition planning is no longer optional, really. I need to stress that agreements and MOUs are not just financial instruments. They are governance instruments that can redefine who set priorities, who controls data, who owns infrastructure, and who is accountable to citizens. Now, I just want to highlight three risks of poorly aligned transition arrangement. One is fragmentation. Bilateral MOUs that bypass national strategies, medium-term expenditure frameworks, and cabinet-approved reforms. That is one. Two, fiscal and legal misalignment. Conditions that contradict national public finance law, procurement regulations, or constitutional guarantees of health. And third is the erosion of sovereignty and accountability. Decisions essentially negotiated between external partners and technical teams with limited parliamentary oversight or community voice. These are the three major risks when it comes to the transition arrangement. So protecting sovereignty does not mean rejecting partnership, but ensuring that every agreement reinforces national obligations and long-term system building. So now, what policy coherent transition arrangement should include? I can just propose a checklist for countries and partners when designing HIV and broader health financing transition agreement. One is alignment with national framework, in the national health policy, HIV strategic plan, universal health coverage roadmaps, and existing public finance law. Explicitly, countries should reference explicitly to the AU or REX commitments. So continental decision cascade down into operational clauses. To the protection of continuity and equity is very important. Clear provision to avoid service disruption, stock out, or loss to follow up, especially for key and vulnerable populations. The use of social protection, insurance, and primary healthcare platform to sustain HIV gains as vertical funding declines. In terms of governance and accountability, transparent roles for ministries of health and finance, parliament, supreme audit institutions, and communities. Data governance clauses such as ownership, access, and use of HIV data must remain with the state, with safeguard for confidentiality and rights. The long-term sustainability and system strengthening, we need to have a kind of gradual, predictable financing trajectory, combining domestic resources, innovative financing, and efficiency measures. Investment in laboratories, supply chain, health workforce, and digital systems that serve HIV and broader health priorities, consistent with the vision that the continent has that needs to be translated into the visions of the countries. Now, I just want to reiterate to close that our challenge is not the lack of commitment. It is ensuring that continental decisions are embedded in national laws, budgets, and contracts. I encourage all of us, especially policymakers, partners, and civil society, to systematically review how the African Union and the regional commitment appear in national legal and financial instruments. Yes, the policies are defined at the continental level, but at the grassroots, the civil society and different partners should look at it, including the parliamentarians. We need also to scrutinize the draft transition MOUs through a sovereignty, rights, and sustainable lens before signing. Concluding to say that we stand ready to work with member states, regional economic communities, partners to develop model clauses, peer learning, and technical support so that transition agreement truly serve African priorities. Thank you so much.
Thank you. Thank you very much, Dr. Benjamin Judalbai, for those insightful remarks on how we can ensure policy coherence while moving with strategic national priorities. And I like what you said about sovereignty does not exclude partnerships. It's not rejection of partnerships. And it is important to keep accountability to citizens, limited community voice and parliamentary oversights have been absent from very specific negotiations on financing, and that does not help with national ownership and leadership. Instead, it erodes sovereignty. Thank you very much for those remarks. I'm now going to move to our next speaker, who is going to help move us from continental commitments and transition arrangements, but to the next conversation, which bring the discussion back to lived realities, equity, and rights. We are going to listen to Mr. Nelson Mutoma, whom we are pleased and honored to welcome in this webinar today. Mr. Nelson Mutoma is the Executive Director of the National Empowerment Network of People Living with HIV/AIDS in Kenya, also known by NEPAC. Mr. Nelson brings an important community and rights-based perspective grounded in advocacy, in lived realities, and the experiences of populations most affected by HIV, particularly around legal environments, stigma, discrimination, and access to services. Mr. Nelson will help us reflect on the legal and social conditions necessary for equitable and sustainable HIV responses across the continent. And of course, this also applies to the broader health system and to other diseases and conditions that afflict people on the continent. Mr. Nelson Utoma, the floor is yours.
Thank you very much, and thank you for the elaborate introduction. I would want also to start by thanking the Africa-led HIV Prevention Working Group for inviting me to this seminar. And of course, we are talking broadly about policy frameworks for sustainable HIV and healthcare financing. This is a webinar where we are talking about financing, but also looking at the resilience series. My input will be around legal environment for populations most affected by HIV. And as you've heard from the introduction, I come from Kenya, and therefore my example to share will come from Kenya. This is really a broad area. But I will also be happy to get back and just remind us that the changing global health and HIV financing landscape calls for innovation so that we sustain the work we started. And in much of Africa, including Kenya, my country, we witnessed the 2025 disruptions with the US government funding freeze. And right now, the way to go is country ownership and country leadership. And I know most countries who are here are talking about integrating HIV into routine healthcare, which actually is a challenge to part of what I'm going to speak about. But there is hope because there are some small pockets of external financing still available from Global Fund. Most of our countries are now in GC8. And of course, the America have come back with the G2G, and I'm encouraged that sovereignty does not mean stopping partnership. But of course, this also comes with the challenge that countries to safeguard their sovereignty will need to be more vigilant. But I'm also here to tell the Africa-led HIV prevention working group that much of this external support goes to what is easy to pick, biomedical. Mostly it ends up being treatment care, but leaves a very huge gap in prevention. Now, I've already talked about how our countries are moving now to make sure that we integrate HIV into primary health care or routine health care. But I'm also encouraged by our countries going forward in February, that is in the 39th African Union Summit, to give a statement on health sovereignty and talk about this as a continental priority, endorsing the roadmap to 2030, but spelling out under Pillar 2 health equity and vulnerable populations. Some of them I'm going to mention here. And it is also important to know that this is not a matter of signing it and agreeing and reaffirming. This is the time to follow this through with legislation, policy, and nurturing legal environment that give most vulnerable populations a genuine and sustainable pathway to care. And of course, delaying country investments means that most vulnerable populations continue to be left behind. In Kenya, our examples are children, adolescents, young people, men, and the people we call key populations. So we can just say, and this every speaker has been mentioning about restrictive legal and social environment, and also punitive laws. But I want to divert and remind us to look at our vulnerability in sub-Saharan Africa and to spell it out in the few minutes I have that adolescent girls and young women, and I'm talking about age 15 to 24 in sub-Saharan Africa, are the most vulnerable population to HIV. They're experiencing infections, but even those who get infected, they are experiencing more AIDS-related deaths than any other group. And this group bears this proportional burden And of course, for those who care about statistics, UNAIDS told us that 3,100 young women and girls were becoming infected every day. That was 2022. I'm not sure whether today that has changed, but probably it has even intensified. But I also want to say that other highly vulnerable groups include key populations that comprise sex workers, men who have sex with men, people who inject or use drugs, and transgender. And of course, the environment, the political environment is not favorable to this group. And because I'm not doing a presentation, I'm speaking, I'm not shy to say that when Trump's stop work order came in, some countries, political leaders in some countries in sub-Saharan Africa celebrated because they said, at long last, we are now not going to deal with key populations. And how wrong were they? Because these are just with like any other population. So I'm going to focus more on the adolescent girls and the young women. You don't have the competencies to address the key populations, but responding to vulnerability of these young people and even susceptibility to AIDS calls upon countries in sub-Saharan Africa to address HIV for what it is, not solely a biomedical issue, but it is deeply social, structural, legal, and political challenge. And as such, countries need to identify cross-cutting issues that fuel the spread of HIV and worsen the impact of AIDS. And this are gender inequality, stigma, discrimination, punitive laws, disregard for human rights, harmful sociocultural norms and traditions, including where gender-based violence are sanctioned, and poverty and other economic factors. So in the case of, and as my time is coming to a close, in the case of adolescent girls and young women, the example I want to give for Kenya is the multisectoral response that the government has mounted, which comprises the biomedical, structural, and behavioral. And biomedical, of course, oral PrEP is still important, and new technologies like vaginal ring, including injectables. But because I work for a network of people living with HIV and affected by it, even ARV falls in this space because for most of us, treatment is prevention. But in terms of structural, we are talking about cash transfers, free schooling, and how to aid these young people also benefit from social vaccines. And of course, behavioral, we have the example of when we go to school, we do comprehensive sexuality education, and we also have to get a few of these people to be mentors to their peers. Now, this is where the challenge belongs as we are in transition. With integration of HIV into primary healthcare, what we have announced to the world is that we are taking back HIV into the health sector and deep inside public health. So how this multisectoral response fits into public health at the time of integration is the challenge that need to be discussed. But for countries like Kenya, I think scaling up strategies that reach vulnerable populations, even in the face of punitive law environment, like revising age where young people can access HIV tests, defining who mature minors or emancipated minors may be so that they get HIV services, the rolling out of triple threat response that also address other structural issues, including things that probably the fifth sector can deal with, and addressing the HIV legal challenges like establishment of HIV tribunal are part of the examples that I want to share that will help us. And more importantly, I was asked to speak. So as I move to the end, I'm happy to conclude by saying that we need to nurture supportive environment to improve the health outcomes of young people. And therefore, it means that governments and partners should create and nurture supportive environment, because there is evidence that removing punitive laws, checking social norms, age of marriage, and also what make young girls vulnerable enhances HIV outcomes. And across the world, when we check and see that countries that don't have discrimination that protect communities and protect young people, and also robust legal environment frameworks, the experience higher rates of treatment uptake and better viral suppression. And if we adopt that in our countries, then we are going to have fewer challenges of HIV and AIDS. Importantly, as I saw in the civil society statement, being prepared for the high-level meeting, the opening statement is AIDS is not over and we still need financing. However, leadership also and the commitment for reform to tackle the many threats facing the most vulnerable populations is still important. So it is not just the financing, it is also making sure that financing is followed by regulating the environment so that we safeguard the harmful threats that make our people vulnerable to HIV and other health ills. And thank you very much for that. I will be happy to respond to any question if there will be one. Thank you.
Thank you. Thank you very much, Mr. Nelson Mutuoma, for sharing your perspectives and some of the experiences in Kenya around the HIV response. And I just want to highlight one important point that you mentioned, which is the multisectoral response. Not that it's the only one, but thank you for your remarks and the experience that comes through your mouth was someone who knows what exactly you are referring to. Thank you. Today's discussion has highlighted that financing sustainability is not only a fiscal issue, but also a question of legislation, governance, implementation, and equity. And our last speaker just emphasized on issues related to equity as well. Before we move to the panel, I'm now inviting Dr. Lita, who was our first speaker for the day. She is now in the position of joining us, and she will be positioning her remarks around legislation as the foundation for durable financing and accountability. Dr. Lita Musimi Ogana, I had introduced you before, so without wasting more time, I'm going now to invite you to take the floor.
Thank you very much, Madam Moderator. I'm delighted to take the floor and actually happy that I am speaking after the other four speakers. I'm in DRC on a very tight mission. So what I did is I put on my earphones when I could not join you, and I was privileged to listen to the speakers that spoke before me. So mine is to complement what they have spoken, but also bring the Union, African Union perspective. Madam Speaker, for me, speaking about this topic is not something that is because I'm the chair of the HIV and AIDS committee. Those of you who may have followed my life, I've been involved in HIV advocacy for the last, since 1986, way back in Kenya, when HIV and AIDS was still mystery. I remember I was the executive director of Family Life Promotion and Services that time, and we had to literally talk to Morioki and Lema to speak up and talk about being HIV and AIDS is not the end of the world. And we saw in Kenya what speaking up for Joe Morioki those days meant in terms of destigmatizing HIV and AIDS. So yes, I'm very pleased to join you and to hear how much progress has been made. 1996 was not yesterday. From that time, we went to Beijing Conference. The African Union came up with the Maputo Protocol. And so at the Commission, we have taken some steps which I would like to share with you. So ladies and gentlemen, in the little time I have, let me say that sustainability of HIV and AIDS And health financing in Africa is not merely a financial or technical issue. It is fundamentally a human rights issue. Sustainable financing determines whether people living with HIV have access to life-saving treatment, whether vulnerable populations are protected from discrimination, whether women and girls can access sexual and reproductive health services, and whether health systems can equitably serve all people without leaving anyone behind. Africa has been in the forefront. I recall when I joined the African Union in 2002, one of the things that we championed was the Maputo reproductive health strategy that is now being revised, which was revised to the current institutional framework that we all know, covering the current period. At the African Union Commission, a lot of distributions have been taken, and I'll be going through them. So, Chair, let me just highlight key African legal and policy frameworks that support sustainable HIV and health financing. And I would like to start with the African Human Rights Framework. Secondly, I would like to talk about EU declarations and decisions on health financing. Thirdly, I would like to talk about the African Union Commission resolutions and mechanisms. And because there is no time, I would have liked to speak about protection of vulnerable and key populations. I would have liked to talk about accountability and equitable service delivery and opportunities for strengthening domestic and sustainable financing. But I don't think I'll have time to do that, so I'll make sure that you get a copy of my presentation. So let me just talk about the first three. So I would like to talk about right to health as a legal and human rights obligation, and I want to situate this in the African Charter. The center of the Africa's normative framework is the African Charter on Human and People's Rights, 1981, under which Article 16.1 of the Charter states that, and I quote, "Every individual shall have the right to enjoy the best attainable state of physical and mental health." Article 16.2 of the Charter says, "We take the necessary measures to protect the health of the people and to ensure that they receive medical attentions when they are at risk." This really tells you that way back in 1985, even before the ICPD in 1994, African Charter recognized the importance of health. The second commitments I want to look at are the African Union commitments on health financing and response to HIV. The first one is the Abuja Declaration on HIV and AIDS, tuberculosis, and other related infectious diseases in 2001. The most significant part of this instrument was that in Abuja, they talked about health financing on HIV, AIDS, tuberculosis, and other infectious diseases. And this was at heads of states level. It is at Abuja that they allocated 15% of national budgets to health sector. And it recognized that HIV AIDS is very important for intervention and remains highly relevant up to today because it underscored the importance of domestic resource mobilization, number one. Number two, it encouraged sustainable and diversified financing. Number three, it recognized health financing as an integral part of development. Number four, it called for strengthened health systems. Number five, it called for promoting affordable medicines and treatment access. And lastly, it also encouraged accountability in health infrastructure and expenditure. Today, we still monitor the implementation of this Abuja 15% target, and that tells you that Africa has not just been waiting from outside. The second is the Abuja Call for Accelerated Action Against Universal Access. This was 2006. And during this was actually a special summit again, in which it was actually a landmark political commitment adopted with the primary goal to achieve universal access to comprehensive HIV/AIDS tuberculosis, and malaria services in Africa. The key highlights of this special summit were universal access to HIV services, increased domestic financing, strengthened partnerships, right-based HIV programming, and health system strengthening. The third pillar of African Union strategy is what we call the Maputo Reproductive Health Strategy, which the initial one was adopted during the what we called the phase when the OAU was had just transformed to AU, and during the Horizon 2007 era. And it is this very important strategy that the current strategy 2016-2030 is anchored on. It was groundbreaking. That time I was the director of women and gender at the African Union Commission. And I can assure you that I work closely with Commissioner Gawanas in trying to let the African Union understand reproductive health as a notion then, and why it was important to translate Maputo Women's Protocol into health for women. The strategy promotes universal health coverage, equitable access to health services, domestic health financing, community participation, and strengthened health governance system. The last one I want to talk about is the Africa We Want, Agenda 2063, which underscores, number one, strong health system, local pharmaceutical manufacturing, domestic financing mechanisms, social protection, gender equality, and inclusive development that leaves no one behind. Madam Chair, the last of these pillars that I want to focus on is the resolutions that the Commission for Human and People's Rights, where I chair the mechanism on the protection of people living with HIV and AIDS seats, we've taken several resolutions. The first one was 53 of 2001 on HIV pandemic, threat against human rights and humanity. This was a landmark resolution by the Commission, the African Commission on Human and People's Rights, and it called member states to 1, allocate adequate national resources, 2, eliminate discrimination against people living with HIV and AIDS then, 3, ensure access to affordable treatment, 4, protect vulnerable populations, and 5th, to integrate human rights to HIV/AIDS response. The second resolution that our commission took was Resolution 163 of 2010. It is established the committee that I chair on the protection of rights of people living with HIV in the continent. The committee's mandate, I will summarize, is 1, to monitor violations of rights of people living with HIV and AIDS, 2, to engage states on legal reforms, 3, to address stigma and discrimination, 4, to promote rights-based HIV/AIDS response, 5th, to protect vulnerable populations, and 6, to strengthen accountability. Chairperson, the last resolution that I want to talk about before I conclude is the Resolution 4446 of 2020 on the rights to health and its financing in Africa. The AHCWG subsequently adopted this, mandating a study on the right to on the right to health and its financing in Africa. The Commission's work highlights several key priority principles. Health financing must be right-based, equitable, transparent, participatory, sustainable, and accountability. Chairperson, let me summarize in conclusion the phases that I think we can, as Africa, have seen this whole issue of HIV/AIDS financing go through. There was an awareness age that happened between ICPD and the Beijing conference and soon after. And then we went to the second phase. That was the phase where we were trying to fight HIV/AIDS with the assets that we had at that time, and non-prescriptive contraceptives, condoms, use of condoms was one of the only way we could face HIV/AIDS. And then Then we went to the era of ARVs, and there was, I'm concluding, Madam Chair, there was the ARV age, and it continues that people with HIV and AIDS can now be able to live and not feel like they're condemned to death. And then what happened? COVID-19 came and eclipsed everything. Eclipsed all the diseases we are talking about, which were in Abuja summit. And for some 2 years, it's like no other disease mattered apart from
Thank you,
COVID-19.
thank you, thank
Yes.
you.
And I want to say that now we are in the era of vaccine, thinking seriously about vaccine for HIV and AIDS and domestic resource mobilization. I thank you.
Thank you. Thank you, Dr. Lita Musimi Ogana, for reminding us of all the legal instruments that are available at continental level to facilitate integration of services, protection of human rights, equity, and accountability to the communities and the people that we serve. We would like now to bring all these pieces together in a short panel where we will have the four speakers that you had the opportunity to listen to, and we will ask them critical questions that will address cross-cutting issues for us to get a better understanding of the critical points that need to be addressed and that are part of the road we are navigating towards a financial infrastructure that is supported by adequate legislative frameworks and policies so that we build sustainable responses to HIV, AIDS, and other diseases and conditions across the continent. So I don't need to introduce them to you any longer. I would like to invite Dr. Benjamin, Dr. Lita, Mr. Nelson, and Mr. Petrus to address the following question. What legal protections survive political transition and fiscal consolidation? This question is going to Dr. Lita, and I would appreciate your very synthesized yet clear response. What legal protections survive political transition from one election cycle to another and fiscal consolidation? Over to you. Dr. Lita, are you with us?
Actually, I was about to exit because, like I said, I'm in the middle of assignments.
Thank
So
you.
I've just put in the chat box that post all the questions to me. Send them to Petros. We will be able to respond later. But for
Thank
now,
you.
I have
Thank
to
you very
give
much.
time.
Thank you. Understood. Thank you. Thank you.
Thank
And all the best with your mission. Thank you very much. Thank you.
Thank you very much.
Thank you. So maybe I will address this question to Mr. Nelson. What legal protections survive political transitions and fiscal consolidation?
Thank you very much for that question. I was happy that question went to another person, but she has left. I can comment into it, but I don't have an answer. I may have a response. But I've checked most of African countries and Kenya. The only thing that has transitioned and beyond political regime change is debt. The debt from IMF, World Bank, from China. But other regimes had very good policies like free primary education to keep girls in school. But when another regime comes up, it is turned upside down. For those who are in Kenya, they understand the maternal child health. There was a policy called Linda Mama, and things probably slightly improved, and then they changed. But I think, broadly speaking, if we can have to repeal our laws, which actually mostly in Kenya and Sub-Saharan Africa we have not repealed, then it will survive the next regime. But for the time being, I think in the space of HIV, the only example I can put is where governments put in AIDS levy. Like the example of Zimbabwe, I don't know how well it works, but I think when you put a law protecting HIV money, then it will survive. In Kenya, we know the previous government also funded HIV when they didn't get global fund. But when subsequent government came in, they went back to external partners. So it is an area that we are still discussing and juggling around. Thank you very much.
Thank you. Thank you, Nelson. Not only you answered my question, but you even gave answers to by indicating what does not survive political transitions. Thank you. That was really very smart. My next question is, how can countries legislate financing? And this time I will just let you decide who would feel better positioned to answer this question. It still be you, Mr. Nelson, or Petros, or Dr. Benjamin. How can countries legislate financing? We have seen what happened in Kenya with the levy. Zimbabwe, I think they still have the levy in place. How can countries legislate financing? Is it possible at all?
Yeah, I'd like to go first. Yeah, I think. Thank you for the question. I think it's possible. Firstly, it is actually possible, and then just taking from the earlier exercise we did on the Mentimeter, we saw that what was coming up as the main concern or issue to say it might be a success factor for us to be able to implement and sustain programs was the political will. So I think that part really needs to come through and not necessarily just become a political statement that comes through in big meetings, either in countries, in parliaments, or also in the collective meetings in Africa. But I think it's something that should be a lived reality that works on that, and I think countries such as Zimbabwe, Kenya, South Africa. I think of late, I stand corrected, I think it's Tanzania that's coming up also with a levy of some kind that then, or in Uganda that would go into that. So I think that's for me the first step in actually ensuring that sustainable financing of program or sustainability of programs is ensured through domestic financing. So it is possible. In South Africa, it's an act of parliament. I think in Zimbabwe, it's the same thing in terms of the AIDS levy that is levied there. In South Africa, we have implemented also a sugar tax levy as well. So that then goes into issues of diseases of lifestyle and helps with health promotion and all that. So it is actually possible where there is a government-led kind of strategy that ensures that happens, but it's actually seen to be weaker in instances where governments only respond or implement some kind of a legislation that works on that only when they are pressurized by advocacy groups and all that, and it's something just lives through that kind of administration, and when administrations change, that changes as well. So I think we need to be very deliberate, but also ensure that we embed the integrated programs within the multi-year, like we've got the medium-term expenditure frameworks in countries.
Thank you. Thank you for giving us clear examples of where it has been possible to legislate financing sustainably beyond annual budget cycles and probably also beyond party politics in government. Thank you. My next question is, what risks do poorly negotiated bilateral transition agreements create to countries, to national sovereignty, and to communities for access to priority services and care? What are the risks of poorly negotiated bilateral agreements? Who wants to address
I
this?
think I can go for that one.
Yes, please.
Yeah, no. Thank you very much. And this is really a very good question. And I see this at 4 levels. Level number 1, they can bypass national planning and budgeting systems. And that is a really big risk because this money will be completely misused because it is not well planned. It is not, budgeted properly. That is number one. Number two, the other risk is to introduce procurement or program conditions that distort national priorities. You see, you take this money, you have the procurement to do, you have to do outside the procurement cycle, and it can distort all this cycle. Number three, it can shift accountability upward to funders instead of outward to citizens and institutions. That is a big risk as well. And the last but not the least is, to expose vulnerable population to service disruptions during, the transition period, for instance. So these are the risks that I really foresee when it's come to this question. Thank you.
Thank you, Dr. Benjamin. And those are very big risks for countries and for communities to continue having access to essential care, not to miss their treatment, and continue to be receiving the attention, the care, and the support they need from their governments. Thank you for highlighting those risks. The next question, and probably the last question I'm going to ask this panel, is which legal reforms, because we are here for the legislative thinking around how to secure sustainable financing across governments and political cycles, which legal reforms are realistic, actionable, and politically feasible within current national context? We know across the continent, we are having different challenges, multiple challenges at country level. Which reforms on the legislative arena are feasible, actionable, politically palatable, acceptable?
So maybe I can touch on that one also briefly. I may not talk about the legislative reform because, the good thing in Africa is that we have all the legal instruments in place. You take each of our countries, we have a fusion of, legal texts, many things. But what we are missing really is the legal alignment with our domestic frameworks and the constitutional obligations. That is really where, so it comes to implementation. We have the frameworks, we have the legal provisions in place, but the alignment is one that is missing. And also the ownership, is another problem that we are facing seriously on the continent and in our different countries. And of course, the transparency, accountability, and clear governance provisions. This is something that is very key. And the one that I can see also is the long-term sustainability and institutional strengthening. So we need to bring all these things together, to make them work. Yeah, but everything is in place. Take each of the countries on the continent, we have all these things in place. Yeah, thank you.
Thank you, Dr. Benjamin. If there is one thing I will work out of this webinar clear in my mind is that we don't need more laws. We have all that it takes for countries to align their constitutional prescriptions and provisions with continental legislative frameworks, own them, account on them, be transparent about them, but most importantly, implement them. Thank you to the panel for that quick chat on some specific questions. We are now going to move to the Q&A session where we will address questions from our audience. And this gives me also an opportunity to remind you that the Mentimeter poll is open. There are questions that we would love you to ask, to address, so that we can collate them and continue to engage with your inputs throughout the webinar. If you have not scanned the code, the QR code, please do so and participate in this interactive exercise that we are having through this webinar. We are 10 minutes to the close, and we will make sure that within the next 10 minutes, we listen to your questions, address them, and then conclude with remarks from our last speaker, last but not least. Please, let's now move to the Q&A session. We had some questions addressed to Dr. Benjamin, to Mr. Nelson, if I'm not mistaken. And here we have Namuinga Chintu asking, are there any early lessons learned from new G2G agreements and how these have been framed to support continental national sovereignty and sustainability while promoting equitable access and quality of care? This question is to Dr. Benjamin from Africa CDC. Another question, in rural Tanzania, we have 3.2 thousand clients under our care to integrate HIV services. It will be difficult for staff to cover the workload. So this is addressing the human resources challenge, not specifically a question, just a comment. And another comment about integration offering opportunities for sustainability and efficiency, but also real risks to quality, equity, and community-led approaches. Dr. Benjamin, would you like to take the question that is addressed to you in the Q&A session?
Yes. I just want to take it very quickly. Initially, we as Africa CDC were not associated to these negotiations. So when it comes also, when it's come to government, you have the national sovereignty that prevails, right? But we draw the attention of our member states on some, critical areas that they should not depart from. When it's come to, for instance, the issue of data, the country should have the ownership when it's come to their data, and the conditionalities should never override domestic laws or approve national priorities. These are the things that really we always draw the attention of our member state, and we always remind them that any exceptional arrangement should be transparent, time-bound, and linked to a clear transition, back into the country system. That is extremely, extremely important. And the government, should negotiate from a whole system perspective, not only from the perspective of one program. So these are the directives that we advise, a country. But these are general principles. But they can go now, discussing specific, like, for instance, when it's come to the American First Global Health Strategy and the MOUs that they were signing with some of the African countries, there are many countries that have stopped that one. Because, for instance, the legislator, we say that, no, this is not aligned, for instance, with our constitution. We have seen that one with Kenya. Zimbabwe is having a very difficult negotiations, and many other countries are having these challenges. So if our advice is required, what I have mentioned is what we give to the member state, but we don't dictate this is the right thing for you to do, but the general principles. So this is what I can say about that question. Thank you.
Thank you. Well said. Thank you very much. Petros, there is a question for you about what we are integrating. Are we integrating people, diseases, or services? If you could address that in half a minute, I would be grateful.
No. We are actually integrating services. So, like I said earlier in the presentation, we are embedding and implementing these programs on our primary health care platform. So, in the PHC facilities, But then, of course, we know those PhD facilities in some cases have to then have some kind of a linkage with communities. So the outreach teams that goes on to communities, but also the community-based kind of system services that are there, either run by the local NGOs and all that. And in some, then I also let me hasten to also mention that we actually do fund NGOs that are community-based organizations from domestic resources to support in running, community, services like the adherence clubs, the pickup points and all of that. Where the gap still exists is on services for key populations. And as we know, there will not necessarily be a full package of all services that can be rendered for key populations that can be rendered in the public health facilities. So with that, we actually are exploring the implementation of that through contracting NGOs to implement those services in the communities or where it's suitable for the key populations to access those services. So yeah, that's what we're doing.
Thank you. And I will add that integration of services actually improves access to care and equity, because as people living with HIV live longer, they are developing many other diseases, namely non-communicable diseases from diabetes to cancer, and the people-centered approach to care, integration of services will make sure that they don't only receive treatment for HIV, but they are also taken care of for other diseases that they might have. Thank you very much for responding to the questions from the public. I would like to invite our participants to continue to add comments into the chat or the Q&A. That will inform our next webinar. Bring your concerns to us. We are now going to look into the Mentimeter, the different questions that were asked, and your answers to that. The poll number 2 was based on the legislative examples discussed. What's the single biggest policy or legal gap affecting sustainable HIV financing in your country? Let's see what comes out of that. The best rated answer is weak accountability for financing commitments, followed by limited legal protections for vulnerable and key populations. And this is dynamic. It's changing along. Let's move to the next poll. In your context, what's the main challenge with translating national HIV strategic plans into sustained implementation? You have several options. There you go. And poll 4, okay. Financing commitments do not translate into budget allocations as one of the main challenges with translating national HIV strategic plans into sustained implementation. Second to that is weak implementation capacity at subnational level. The next poll is, from what you have heard today, what principles should be non-negotiable in HIV transition agreements or government-to-government MOUs? You have options. Actually, these are answers that we are receiving. Okay, equitable access should not be negotiated. It's non-negotiable. Audit of debts, equity, people-centered MOUs, not business extractive interests. Freedom to invest resources in infrastructure gaps that support long-term sustainability is non-negotiable, according to one of our participants. Audits of debts in African countries to really release money for development. Transition is a journey that begins with engaging the populations whose lives will be lost if transition is not planned carefully. Social contracting is non-negotiable. Do we have another question for our participants? I believe this is the last one. Which legal or policy reform would have the greatest impact on improving HIV outcomes for populations most affected by HIV in your context? Top of the list so far, removing legal and policy barriers to service access, reduce stigma, discrimination, and criminalization. Poll 6, in one sentence, what message will you take forward to strengthen sustainable HIV financing in national AU or ARFSD 12 discussions? Old strategy, no new way. Equity-centered financing, funding community, funding prevention, last mile access first. I believe we have come to the last question of the Mentimeter, and I would like now to move to the closing segment of this webinar. I would like to sincerely apologize for going over time. And I also apologize to Dr. Coutinho for having eaten up on his time where he would give us high-level advocacy messages and closing remarks in a much more reduced time. Dr. Alex Coutinho is the director of the Kofi Annan Global Health Leadership Program. The floor is yours. Thank you for joining us today. And thanks to all of you for being with us for this webinar today. Thank you. Dr. Alex.
Thank you, Dr. Magda, and thank you to all of our speakers and our participants. In the short time, let me summarize what my reflections are. This seminar was about policy frameworks for sustainable HIV and healthcare financing. Over the 90 minutes, we have talked about this, but also addressed a much broader issue of what does sustainability look like and what does it take beyond money to sustain HIV and healthcare services. Some of the key words that the participants identified that came to the top that are required for this HIV sustainability are issues around political will, issues around donor fragmentation, and issues around corruption. There were several other issues raised, but these are right up there. So in summary, I think what we have heard is that sustainability is not just about finance. It involves strategy, it involves governance, it involves legislation, it involves broad policies that are multisectoral, it involves a very broad social environment, and it requires country and government leadership. And at the center of it all is the recognition that we are talking about a human rights issue, the right of health as a legal and human right. And even though sustainability is not just about finance, financing remains key. And we need to think again and be innovative around domestic financing, around the funding we get from partners, about how we integrate services, about how we achieve efficiencies. And very important to me is where we get our return on investment, particularly in HIV prevention, that seems to be being squeezed out and focusing on urgent treatment, which is required. So we heard from Dr. Musiemi and Dr. Benjamin about all of the continental frameworks in the AU and in Africa CDC. These are really important because they provide a platform for political commitment across Africa. They are also the starting point for key country policies and strategies and financing. And they also provide a country peer-to-peer accountability mechanism to compare progress. But we've heard clearly, particularly from the speakers at the front line, in South Africa and Kenya, Petros Koza and Nelson from Kenya, that there is mixed translation of these frameworks at country level. And there is a lot of work still needed on cascading political commitment to national programs that will serve our people. So in summary, Africa has plenty of frameworks, has plenty of laws, plenty of commitments. What is perhaps lacking to provide the sustainability is clear implementation plans and innovative ways to drive to increase domestic financing. And I personally would say, perhaps we need to set a target, just like we set the target of 15%, to a target of what percentage of our health funding should be driven domestically. And we will need to ask ourselves, what national laws and policies need to change around the areas of taxation, public-private partnerships, national health insurance, primary healthcare financing, and public health financing, and how all these and others can come together to support both HIV and healthcare services. Thank you very much, Dr. Magda.
Thank you. Thank you very much, Dr. Coutinho, for that great summary in such a compressed period of time. Before we say goodbye, we want to invite you to our next webinar, which will be on the regulatory environments and resilience partnership models that we need in this time of transition, uncertainty, and unpredictability. Save the date. It's going to be on the 24th of June, 2026, and you have the times and the QR code that you need to scan to register. Thank you, all of you. Thank you, everyone, for being with us today. We hope you have enjoyed this discussion. We hope you enjoyed the conversation. And most importantly, we hope that you have had lessons that you can take back home and apply in your respective context. We have been with you. We had the African-led HIV control working group, and we are working towards HIV/AIDS and healthcare response that is grounded on the realities of the continent, that is led and owned by the leadership, the communities, and the people in the nations of the African continent. I thank you. I was your moderator for today. My name is Magda Robalo. Thank you.